you can see my screen. So, as an introduction, for the cranial cervical jump-in. So, you have these hypermobile bones, you have very unique anatomy. And then, you have multiple ligaments here, the transverse ligament being the strongest, as well as the lateral capsular ligaments from the facets, that you don't see here, followed by, the alar ligament and the pectoral membrane. So all these are real important for stability across this region. And then, this is a picture from Dr. Roten's dissections that really just shows how complex it is. It's not just, bones and fixation. There's venous plexi, the vert, cranial nerves, spinal cord. It's a really complex region. And as you can see from our recent CSF lab,
Very nice.
we're navigating it pretty well. So, and there's a high rate of distracting injuries, right? Cervical spine trauma in general, as well as all trauma. So you have to be on the lookout for any intracranial findings, as well as any kind of body injuries on your initial workup. And it's always important to remember the ABCs along those same lines. Remember to elevate the maps if the patient's weak to maximize blood flow to the spinal cord. And immobilization is essential in the initial management of any cervical spine trauma. So you can obviously a C-collar, but you can consider in a pediatric patient or a patient who's not able to lay still, to put sandbags on either side of the head. In addition to that, on initial imaging workup, certainly before surgery, always think about vascular injuries. They can happen. It says about 20% of cervical fractures. But particularly if the fracture is going anywhere near the transverse foramen, something important to think about. And CTA is the most sensitive to detect any kind of vert injury or other vascular injury. And then, certainly we don't have to pan scan everyone. If you have a patient who's alert, who's awake, they don't have a neurodeficit, they're not intoxicated, you can avoid a CT in many circumstances, but this is primarily being done by the ER physicians. And you can see a lot from a plain X-ray. If you look at the anterior, middle columns, posterior column, and just kind of see what the alignment looks like, a lot of the times you can see, where something would be awry and can tell where most injuries would be. That being said, the vast majority of our patients start out with CTs because X-rays are not sufficient to rule out a trauma. So that's typically the workup, the start of the workup. Sometimes we'll see MRIs first, not quite sensitive enough to detect fractures. So starting from the top, starting with occipital condyle fractures. So the clinical presentation is highly variable. Most of the time, these are high velocity mechanisms, either a high level fall or an MVC. And the load of force will transmit cranially down from the occiput to the occipital condyles to the C1 lateral mass to the C2 lateral mass, kind of shown like this coronal view in this picture. And up to 30% of patients can have some cranial nerve pathology, so it's important to include that on the exam. Here's essentially showing that there's also very commonly other cervical spine injuries. So it's important to look at the entire cervical spine. So the classification starts with type 1, which is an impaction comminuted fracture of the condyle that's stable. If the fracture is bilateral and looks like this, it's important to assess alignment. But overall, that these fractures can be treated safely with a collar. Type 2 fractures are more extensive. They go through the skull base. They can become a problem with avulsion. So you need to assess the ligaments on the MRI. And typically, these also can be treated with a hard collar as well as a halo if the condyle is displaced from the skull. Type 3, these are the shear fractures through the skull base. And it's near the alar ligament insertion. So if the alar ligament's injured with the fracture, the condyle can be displaced. You need to consider a halo versus an occipital cervical fusion, given the degree of malalignment or ligamentous injury. Moving on to AOD. So AOD is much higher risk in younger patients, and that's just because of their regional anatomy. So they have larger head to body ratio, they have flatter occipital condyles. It's a very common cause of death in high speed MVCs with high rate of neurologic deficits. and evaluations made by CT and MRI scan. And then on surviving patients, this diagnosis is often missed and overlooked. And that's just because the finding of, as they essentially have done more studies and more patients are surviving, they're finding that the correlation of the worse radiographic injuries are related to neurologic outcomes, which makes sense. Nowadays, we have more survivors. Likely it's due to better EMS and getting patients into the hospital. And then here's some studies that show, as time passes, more patients are survived. And then all these patients, when they come in and you find concern for AOD, they need a collar, they need a sign saying unstable craniocervical junction on their door, and they need sandbags if possible, if there's any concern that they would move, to make sure that they don't move at all because they're high risk for neurologic compromise. So looking at the metrics to measure AOD, so traditionally we've learned this powers ratio, which is the distance from the basion to the posterior arch of C1 and then the epicyon to the anterior arch of C1. It can give you a general picture. If the number is greater than 1, it suggests that there's an anterior translation, but you can also have a false negative if there's a distraction injury straight upward. And if there's a posterior dislocation, you'd think that the number would be very low. So the Trainellis classification comes in here, where it essentially shows which direction the atlanto-occipital dislocation is in. So, essentially, if you see something that is off on the X-ray or the CT, think further and do these measurements. They may not always tell the tale, but they can at least give you a hint of what's going on. Further, you can look at the BDI, that if that's greater than 12 millimeters, that suggests dislocation, the distance between the basion and the dens. As well as if you look on the CT scan and you see the occipital condyle, the C1 is greater than 4 millimeters, that's something else to keep an eye on as being irregular. So what further do you do with these patients after getting their imaging workup and immobilizing them? Acute flexion extension X-rays are contraindicated. They can be helpful in the initial trauma setting to determine stability, but most of the time they'll want one of us to be down there to make sure the patient's not flexing or extending too far, causing some kind of transient neurologic symptoms. Some classification symptoms have looked at traction to demonstrate AOD. I would say if you have a clear diagnosis and you can avoid doing this, that would be kind of the most prudent. And you can see on the MRI scan, hematoma, ligamentous injury, any cord signal change. So hopefully that can give you a good enough picture if there's an injury there. And then treatment involves consideration of placing a temporary halo vest, as well as a definitive treatment of occipital cervical fusion. Moving down to the atlas, so C1 fractures typically occur in the anterior and posterior arch of C1. And it's important to distinguish this from just an anatomic variant of incomplete posterior C1 ring. And most commonly, it's due to a fall on one's head with an axial load type injury. So neurologic injuries uncommon in these fractures. And the key is to look at the integrity of the transverse ligament, and that will kind of dictate the stability of this type of fracture. There's some measurements on X-rays we can look at to help guide the termination of the transverse ligament being intact. So you can look at this initially, looking at the ADI being less than 3 or less than 5 in kids, and as well as the rule of Spence, which is the sum of the C1-2 lateral mass overhang. And you can see that on an open mouth odontoid view, that being less than 7 millimeters. And then you can also look at the ligament directly on the MRI scan. So that's what it's attempted to show here on this MRI scan. And then notably at C1, before you do, planning for surgery, it's important to look where the vert is, because it goes posteriorly almost up to midline in some cases. It can, normally it's 2 to 2.5 centimeters away from the midline, but it can be up to, 5 millimeters in some cases. So this is often your first screening tool where you can see that on an MRI scan and decide if you need further workup with a CTA. And then the classification for atlas fractures. So type 1 is an isolated anterior or posterior arch fracture. This is the most common injury pattern. It's overall a stable injury and it's treated with a hard collar. a Jefferson fracture or these type 2 burst fractures include bilateral fractures of the anterior and posterior arch and also result from the same mechanism. And if the transverse ligament is intact, you can also treat these with a hard collar. If disrupted, you should consider a halo vest for a bony avulsion, which I try to show here in this bottom right image, or if the transverse ligament is injured through the ligament, you have to consider a C1-2 fusion. Type 3 fractures include unilateral lateral mass fractures. So disability is also determined here by the transverse ligament. And if stable, you could treat with a hard collar, and these typically would heal over time. So further, this is looking at a classification. A and B kind of show that the transverse ligament is disrupted, but in cases like C and D, you can consider putting this patient in a halo, and hopefully that this would heal over time. About 75% of patients with these can heal without C1-2 being fused and having the limitations that occur from that. Moving on to odontoid fractures. So, they're famously classified by Anderson and Alonso into 3 types. Is the most common neck fracture in patients that are greater than 70. And that's due to just kind of normal physiologic degradation of the dens that comes from a loss of cortical thickness, decreased trabecular volume, weakening of the bone connectivity, sort of like the femoral neck of the cervical spine. And then like C1 fractures, if the transverse ligament is torn or disrupted, it's a problem. And these type 1 fractures are fractures through the tip of the dens. They're typically treated with a collar. Definitely type 2s are surgical, and type 3s, if there's any angulation or displacement, you should consider the patient for surgery as well. Specifically, there's often a question when a patient comes in, what's a type 2 and what's a type 3? And, if there's true cancellous body involvement, typically that is a type 3. Type 2 fractures would typically not enter the C1-2 joint, whereas type 3s can. And you can see this often best on coronal CT. And the nomenclature is all over the place for C2. I mean, there's the area that's just anterior to the transverse ligament. People will describe as the waist or the neck or the stem or the base of the odontoid, which is also called the peg or the den. So I was part of some work at Tulane with Shane Tubbs that looked at trying to classify a definition of what the dens is a little bit more in detail. And I think it makes sense to have an embryologic basis for this. So what's denoted here is this subdental synchondrosis that can be present in up to 30% of adults, but most people lose it around the age of 12. So using that as the definition of the dens can be valuable, and especially in helping classify these fractures. Here's a better picture showing the growth plate. So you can see that apex of the dens, the top 4, develops from a secondary ossification center, while the remainder is formed from these 2 lateral ossification centers with the subdental synchondrosis underneath. So when you're making a classification system just of this anatomic dens, typically this upper, this type 1 involved the upper 4th, and type 2 would be anything above the growth plate. So the distinction between type 2s and type 3s in the Anderson-Alonso classification, you can see from the right image, sometimes this can give you a clear picture. And then Grauer and Vaccaro demonstrated type 2 odontoid fractures, subtypes specifically for type 2s in the early 2000s. So, A's are these fractures that have no displacement and have a linear line through them. B's have this more oblique, as well as C have these more oblique fracture lines. And essentially, it shows the type of procedure that may be appropriate. Essentially, that in type B's, you could consider an odontoid screw, whereas in type C's, that's not really an option. And I think it's essential in odontoid fractures to discuss patient population, which is increasingly an elderly population. And in geriatric patients, this is the most common spinal fracture. 95% of them are type 2. It affects more women than men, but it can happen just after any low energy fall, as we all see when patients come into the hospital. But there's rightfully some amount of personalization that comes with decision making, but more recent data has suggested a benefit to treatment, both in quality of life and mortality for these fractures, as opposed to having someone in a collar for life. Some background in talking about surgery. So there's an older study here that essentially looked at observation of type 2 fractures without surgery or mobilization, and essentially resulted in 100% non-union. So, these fractures don't heal on their own without any kind of treatment at all, as shown by that observation. So what's the evidence for treatment of a type 2 odontoid fracture with just a hard collar? Most patients will go on not to fuse. However, they might obtain a stable fibrous union, which can allow for a good functional outcome and pain-free living in some circumstances, which may be acceptable. So I think it's important to highlight that also the initial studies here by Clark and White, looked when they talked about patients treated non-operatively, they were putting people in traction for 4 to 6 weeks, followed by a collar after that. So to achieve a rate that's that high with non-operative management is involving extensive limitations. And in geriatric patients, even simply wearing a collar at all at times can be very morbid, limiting eating and their function. These are all things to consider for non-operative treatment. The study furthers the case that fusion might not always be necessary. Stable fibrous union might be an acceptable result. They found there was no difference in pain scores at 1 year between the operative and non-operative patients, although many of the non-unions did go on to require subsequent surgery. So now looking at treatment options. So the first of which is halo mobilization. So this is a very poor option for elderly patients with type 2 fractures because they just don't tolerate it very well. There's a high rate of complications. One study found 21 times more likely to fail than those less than 50. And a trauma study that looked at patients older than 65 and kind of stratified them found that despite the younger patients having more severe injuries, their complication risk was much higher in the older patients, including pulmonary issues from aspiration pneumonia. And pin site problems were more prevalent. So halo is a poor option for older patients. And then I thought this was an interesting study. It looked at this nationwide registry of inpatient diagnosis codes for type 2 odontoid fractures. So from 2003 to 2017, mean age of 77, 86% of patients now are receiving surgery compared to 46% in 2003. So the trend is leaning toward more operations, despite patients being elderly when they get this fracture. So what was interesting about it is obviously there's some patient selection that goes into it, but the inpatient mortality was better in the operative group compared to the non-operative group. So it could be that the people that are getting surgery, have less severe or better operative candidates, but overall they seem to be doing better than the people that are not getting surgery just based on this registry. And then looking at some treatment options. So, first is anterior odontoid screw. So this is a fantastic surgery. I think it's a truly, great operation. It's minimally invasive. It spares rotation at C1-2. But it's really just hard to find the right patient for it, I think. And most importantly, when trying to select a patient for it, they should be this type 2 subclass B fracture pattern. So the fracture should be perpendicular to the placement of the screw. And then, other contraindications include a chronic fracture, displacement, transverse ligament injury, as well as, short neck or barrel chest. So I think if you're considering a patient for the surgery, it'd be useful to have them lay down, like on the exam table or in pre-op, just because, you never know sometimes until you get there that how prominent someone's chest is when you're trying to find that angle all the way, which is quite steep for an odontoid screw. And there's also a risk of dysphagia in older patients. So, and then the gold standard procedure for type 2 fractures is posterior C1-2 fusion. So, there's a variety of options for fixation, the most common being C1 lateral mass and C2 pars or pedicle screws. And I think it's nice in these cases when you can decorticate the C1-2 joint, you can follow the pars all the way up, and you can even put graft in there. And there's options. You can take the C2 nerve root if it's in the way of your C1 lateral mass screw as well. Here's a case from my residency I want to present that kind of illustrates what we're talking about in these patients that come in that are older and they have fall from standing. And, this image was on the initial consultation, but the patient came back in at 90, a year and a half after initial presentation. So, relatively, mild comorbidities, older patient. neuro intact, but was having like intermittent quadriparesis when they came back a year and a half after the scan. And then you can see the updated CT where the odontoid is translated back. There's evidence of cranial settling. There's cord compression. So, over time, this fracture did not heal, did not obtain a stable fibrous union, and there became symptomatic. So, we essentially this had a conversation with the patient and family. Even at the age of 90, we placed 10 pounds of traction, tried to realign the odontoid a little bit before surgery, and then took the patient for occipital to C4 fusion. And you can see the options you have at C2. So we did the bicortical midline keel fixation, and then had to put in, because of the anatomy, had to put in short par screws. So we put a second translaminar screw on one side at C2. And the patient did well from the hospitalization, but I think it's a case where you see that kind of treatment plan had to be escalated after conservative management. So as much as we like to do this for people, it's kind of a cautionary tale that it can lead to displacement, rotation, cranial settling. It might require extension of the occiput or additional levels that may have not been required if the fracture was treated up front. And then the last fracture pattern is a C2 bilateral pars fractures or hangman's fractures that can occur from hyperextension. So, rarely do these fractures involve neurologic injury. They're classified into three types. The first of which has minimal displacement and no angulation. So these patients in type 1s can be treated with just a cervical collar. Type 2s involve 3 millimeters of displacement and angulation with disruption of the C2-3 disc. This is from hyperextension with rebound hyperflexion. And the treatment can be closed reduction with halo, or it can be C2-3 fusion, such as C2-3 ACDF. And type 2As are flexion distraction injuries that have angulation without any horizontal displacement. So the same story goes, but notably traction is contraindicated due to the ligament injury. And treatment is with a halo. And then type 3s are the more severe. They essentially involve a similar injury, but there's also facet dislocation, jump facets at C2-3. And this has a higher rate of neurologic injury. So for these patients, typically you'd require surgery with a posterior C1-3 fusion. And lastly, I think the traumatic indications for extension to the occiput are rightfully rare. Unlike extending a fusion to pelvis, the occiput carries with it much more morbidity due to loss of flexion extension. But you can use it as a strong anchor if you have to. So, the indications being AOD, a C1 burst fracture with unsuitable C1 lateral masses, and severe C2 fracture with rotation or malalignment. And when you get these patients in the OR, you have to make sure that their head is nicely positioned neutrally, because you're planning to fixate along those lines. Typically it's done at the keel where the bone is the thickest and measured intraoperatively to make sure that your screws bicortical. You can also do a muscle cuff if you want to try to avoid that area being prominent, in your closure. So, and then your options at C1, your lateral mass screws, traditionally, and then you can also do a palm screw that, may be slightly stronger. And then options at C2 are, far and wide that all have various strengths and are based on patient-specific anatomy and factors. So that's all I had. So happy to take any comments or questions.
Any comments on rotary subluxation or rotary fixation, mostly in children?
Rotatory subluxation in children. Gosh, I didn't look into that specifically, Dr. A, but that can be very challenging.
It is really common with obviously inflammation as well as traumatic, but cases.
You're fading, Dr. A.
I'm in the plane. A lot of noise, but something that you can refer to or look at it yourself. Thank you very much for great presentation.
Thank you.
Good talk. Much to add. I think the C2s are a little bit orthopedic like hip fractures. A little nuance there, but
Yeah.
if we get better, pass out at fixing them, probably lead us a little bit in the direction of the reasons that you stated. The missing link for me is I'm not super comfortable with the awareness of what percentage of those patients go on, number one, to need surgery, and number two, to have neurologic sequelae from not fixing them
Right.
versus just expire.
Yeah, it seems low.
And you'd kind of want to know that as a patient, right? Or as a family member of the patient, you want to know those specific numbers to really make a decision. Should I get through it?
Right.
Should I take the risk of surgery?